Thank you so much. Thank you, John. And thank you all for being here today. It's an honor to be with all of you. It's hard to follow this beautiful tribute that you just gave to everybody. So thank you for that. And I think when I reiterate a little bit of the message that you gave in terms of a lot of times when we talk about Parkinson's or think about Parkinson's, we focus more on the motor limb symptoms, right? How we walk, how we move. So in addition to the emotional and cognitive aspects, I'm going to add some more information that I want you to be aware of on eating and swallowing, because that's also a big part of our daily lives. It's what keeps us alive, right? And also it keeps us happy. We love food, right? Anybody doesn't love food here? Let's see. No? Okay. All right. Okay. So everybody with me. Well, thank you so much for the opportunity. Just very, very few things about me. As you can probably hear, I have an accent. That's because I am from Greece originally. That's where I grew up. And I did my undergraduate in speech language therapy. Then I came to the US. I use this joke a lot. I traveled from Athens, Greece to Athens, Ohio to do my master's at Ohio University. And then I did actually my PhD at the University of Illinois, and I think that's one thing that we have in common with John, right? UIUC alumni. Then I spent some years at the University of Wisconsin in Madison at the Department of Medicine. I did a postdoc there and worked clinically before I went back to academia to be a professor. And my first faculty job was actually in New York City at Columbia University. Then Purdue recruited me, and I'm really, really happy to be here for the past 10 years. So it's been really wonderful to be at Purdue and in Indiana and offer some services to Indiana folks that were not available before. So we're really excited about that. So with that, very briefly, these are my disclosures. So some of the work that I will be presenting today has been funded by either Purdue or federal research grants by the different institutes within the National Institute of Health. So we're very, very thankful to all of them, as well as to our private donors. So at Purdue, as I said, I joined Purdue 10 years ago. And one of the first things that we did, we established the first research in swallowing and swallowing disorders for patients, especially with neurological disease. So Parkinson's and stroke are the primary two populations that we study and we want to help. So our lab, I just wanted you to, and I will share the slides so that you have all this information so you don't need to write down anything right now. I'm happy to share everything. But this is our lab website, and it details some of the work that we do. We primarily focus on better understanding how the body controls swallowing, because that was something that used to be believed for many years that it was just a simple reflex. And we're finding out, as you will learn today, that it's much more complex than a simple reflex in the body, much more complex than that. So we want to understand that control better and then develop treatments and examine how good these treatments are for patients. And finally, something that became really popular post-COVID was also, but was always needed, I believe, how do we make these treatments more accessible to people? So that's where telehealth comes in, right? And being able to provide some of the services via telehealth. So we're going to talk about all of that. And if you have questions even in between, please feel free to stop me. But we will also, I believe, have quite a bit of time for questions at the end. So eating, swallowing, and Parkinson's disease. So what do these things kind of have in common, or the common thread? The common thread is the nervous system, like with other sensory and motor functions of the body. For swallowing and eating, we use all the levels of the nervous system, from the muscles to sensory receptors that will help us taste, feel the temperature, texture of foods and things like that, right? All the way to centers at the lowest part of the brain called the brainstem. That's where your nerves start, many nerves, as well as the brain itself. So all the levels of the nervous system are involved in some aspect of eating and swallowing. And you probably have heard this, and it's true. In our brain alone, we have billions of neural cells or neurons. Our entire nervous system has even more. These neurons communicate with each other through electrical signals. It's like almost like cables connecting to each other, right? And providing these signals. So just the signals that are going on between the head and neck and the brain when you eat and swallow, we're talking about thousands of electrical signals going on. So just to kind of understand a little bit of the complexity of that. So I want you to imagine that even when you sit down to eat, today for lunch, for example, every time before you even take a bite, you need to do what? Look at the food, smell the food, make a cognitive decision if it's something you want to eat or not, make a cognitive selection between different foods, and then transport the food into your mouth. Even those processes, before we even talk about swallowing, take thousands of electrical signals that are shared between your head and neck and the brain all the time. And then, to add to that complexity, just so that we get a better understanding, to complete just a single safe swallow of one bite of food or one sip of liquid, you need at least 5 different types of sensory cells in the head, in the mouth and throat that, again, will sense the food, the temperature, the texture, those types of things, will help you smell, right? To transfer that information to the brain. And you also need more than 40 pairs of muscles in the head and neck. You need more muscles to swallow than you need to walk. It's really impressive. They're very much smaller than the ones that you need to walk because they're all right here in the head and neck area, but they all have to work well and be well coordinated, and a lot of nerves as well. In addition, and so that's something that we have been learning for the past couple of decades now, that the brain is also very, very involved. So you can understand that if the brain is involved in areas that are typically impacted, unfortunately, in Parkinson's disease, then probably there will be some effects on swallowing, some impact on swallowing as well and eating. So what does it look like to swallow? And some of you may have seen this if you have been in any of my talks before. But has anybody recognized what this image is? Yeah, a couple of people do? Okay. So this is an image of what is called a real-time X-ray video of a swallow. Okay. So if you ever are evaluated for a swallow, this is the examination they're going to do. It's called video fluoroscopy. It's a real-time X-ray video, okay? And just so that you understand, so usually you will be in the radiology suite. There will be a radiologist there and a speech pathologist, and they would take a camera on the side of your head and neck, and that's what this is happening, right? There's a camera here, and it's taking a video of this person's swallow, okay? So what we can see some structures that we can probably all identify. You can see, let me use there you go. This is a little bit, sorry about that. Okay, stronger. So this is the jaw, okay? This is this person's teeth, so you can identify this is the mouth. The roof of the mouth is here, okay? And then at the back of the mouth, there is this big tube it's open right now. It's called the pharynx. The back of the throat is the pharynx, okay? At the bottom of the pharynx, here you have the beginning of your esophagus, the food pipe. And then right in front of the esophagus, right in front of where the food is supposed to go, you have your airway. So, sometimes when we say the food went down the wrong pipe, it's exactly what's happening. Food, instead of going all the way back, it goes at the front, right? Where it's not supposed to, okay? So this is what the anatomy looks like. This is a healthy young person. And now I'm going to play their swallow so that you can understand what it is and how quick it is. So you will see a liquid coming all the way from the mouth all the way down. And I want you to try and watch. I'll play it a couple of times. What are these structures doing? You will see that they are moving to make sure that we swallow safely. Okay, now play it a couple of times. You see how it happens? Pretty fast, huh? So these structures are moving up and are closing the airway so that the food can go safely to your food pipe. Does that make sense? So that's a healthy young swallow. Now, unfortunately, as with every other sensory and motor function of the body, as we age, just typical aging, what do you think happens to our swallow? It changes a little bit, right? Why does it change? Because, as we get older, unfortunately, we can't smell or taste as well. Our sensory receptors are not working as well. But also, we have some loss of muscle mass. Now a lot of us are into exercise to try and counteract that, which is good. but we do lose some muscle mass, and in the head and neck muscles as well. Our cartilages also become a little bit harder, and we don't produce as much saliva. But then, as we age, we also take a lot of meds. Some of them will cause dry mouth and some other side effects. We may lose some of our teeth or need to use dentures. So all of these factors together sometimes can make our swallow a little bit different as we age. So what does it look like when we age? So now you are going to tell me if you see any difference from the previous one, okay? I'm going to play this one. And tell me, you can just shout out if you see anything different. This is the exact same amount of liquid being swallowed by this person who is just an older, healthy person.
Is it straight down?
Mm-hmm. Yes. What else?
The passage isn't closing as much.
Yes, the passage is not closing as much, so it has a little bit of a, almost like wanting to go down the wrong pipe. It doesn't, it never does. Anything else?
Well, it appears that they have to swallow, take 2 hits and swallow.
Yes, they swallowed twice, right? The same volume. It was slower, they had to swallow twice. It's still normal. This is, this person is still a functional eater, enjoying food. It's just a healthy, part of healthy aging. But just wanted you to understand that happens to all of us as we get older. We're still, and most of us can accommodate for these changes really well, right? We still are able to enjoy food until very late in life, and everything is good. And we want the same for our patients with Parkinson's. But what happens in Parkinson's, okay, that is a little bit different. So in Parkinson's, you probably have heard of these terms before. I'm going to kind of try to simplify them. Although, as you know very well, probably better than me, the exact pathology of Parkinson's is still being investigated. Because if we knew it, we would have a cure, which would be great. But I think we're getting there. There's lots of really fantastic work. But the two main mechanisms that we are suspecting are, not suspecting, we know that they are reduced in Parkinson's. One has to do with dopamine and loss of dopamine in the neurons that are producing dopamine, and especially with a primary focus area in the basal ganglia deep inside the brain. Now that loss, in the basal ganglia is also known to create deficits, help us develop deficits in motor coordination, motor initiation, and slowness of movement, not just for the limbs, but also for the head and neck muscles, because the basal ganglia system is important for the system of the head and neck and more of the axial or central muscles of the brain as well. So that's one mechanism. So because of that, we do see reduced coordination and slowness in head and neck and the breathing muscles as well. So that's one kind of mechanism that we have to think about for Parkinson's and for our patients that may have swallowing problems. The second mechanism that we believe is also is a newer, relatively newer or more recent discovery, is that in addition to the dopamine loss, we also have in Parkinson's disease, in many of our patients, these Lewy bodies being developed on the cells themselves. So these are groups of abnormal proteins that are not supposed to be there, that are being found now in certain areas of the brain. And it used to be, again, they were focusing more on basal ganglia, but now they're finding these Lewy bodies almost everywhere, unfortunately. They're finding them in the surface of the brain, the cortex. They're finding them on peripheral nerves and even in the gut. That's why they talk a lot about the gut-brain connection. And now they even talk about GI, gastrointestinal disorders, being present way before somebody gets diagnosed, because some of these proteins are accumulated very early on in kind of the prodromal PD stage, as they call it. So these deficits in nerves affect both sensory aspects and also cause weakness. We can't use your muscles as much, so you use them less, so then your muscles get weaker, get an atrophy more. So, and this is the same for head and neck and breathing muscles. Yes?
My wife has been diagnosed with Lewy bodies in the brain.
Yes.
How are the other parts of the body tested for Lewy bodies?
So most of that work that has been done, either in animals or in autopsies. So they, later on, they will actually look in the tissue itself, and they are discovering these Lewy bodies. So I don't know that they are. There may be, but because I'm not an expert in this, but I don't know that they. Most of the research that I've read on this has mostly been in animal models, and from patients, post-mortem, that they have found these accumulations in different parts of the system. Yeah. But that's a good question maybe for the neurologists. They may know. They will know, if there are some ways to actually test for these in other areas of the body. Yeah. Any other questions? Okay. So we actually have, and I'm going to present this very quickly because I don't want to get too technical and lose you from technicalities, but I just wanted you to know that in the area of swallowing research specifically for Parkinson's, there have been several studies now, and I'm only choosing 3 to just showcase some examples that have shown that there are some reductions in those functions that I've been talking about. So for example, this is a study where they used something called pharyngeal manometry. That is a tube that goes through the nose into the throat that has pressure sensors that can sense how well the patient, when they swallow, how well they can push down the food. Okay, so how strong the throat basically is. And they have found that when you compare healthy subjects with patients with Parkinson's disease, those pressures are lower in the throat, but also they're a lot more variable. Do you see there's a lot, those lines go, multiple ways, whereas the control group kind of had a really more uniform and cohesive type of, so that was one of the studies. And actually these were early stage Parkinson's patients that were not complaining of any swallowing problems. So that was really, really an interesting study because it was one of the first that showed that even before you have obvious, overt swallowing issues like aspiration or things going down, the wrong pipe, there are changes that are happening in the oral and throat mechanisms that you need to be aware of. This is a newer study that looked at, again, very complex figure. I'm going to explain it very simply. They looked at how strong your tongue is and what is your likelihood of getting things down the wrong pipe, aspiration, severity. And they saw, and they had, I think, 40 to 50 patients, if I remember correctly, and the lower your tongue strength, the more likely you were to aspirate. So again, some connections between oropharyngeal strength and actually airway protection or airway invasion in the opposite sign. And this one other study looked at cough effectiveness. So this is a system actually we have at Purdue as well, where you wear a mask and you cough into the mask, and we can measure the strength of your cough, the airflow of the cough. We can make a lot of different measurements. And here you see an example of how different the graph would look if a healthy person is coughing, like a very sharp cough, pretty strong, versus a person with Parkinson's disease. And again, a lot of these patients are in the mild or moderate stages when they come in. Yes?
Is there any effect of CPAP with all of this?
So I don't know that there has been studies on CPAP or any effect on swallowing, but I do know that there is an interest now of looking into sleep apnea and swallowing because some of the structures at the back of the throat are the same, right, and the muscles that are used. So there's a lot of interest in research, but I don't believe that I have seen anything that specifically has investigated how CPAP use could affect swallowing. But there may be some connections there. I know what you mean, yes. So in our work, we are using, one of the methods we are using are, we're using something called electromyography, which means muscle readers that attach to the skin to measure muscle activity. So we are seeing that despite these reductions that people see in different aspects of strength or coordination for patients with Parkinson's, when they swallow normally, they typically tend to need more effort than people of the same age group that do not have Parkinson's. So when they just do swallow liquids and solids just like they would when they're eating a meal, they are trying harder than, so although and it's possible because they are weaker in all these other domains, they are trying harder. So this is telling us that we have these reductions in muscle strength and coordination on one hand. On the other hand, the patients themselves, you all, try to overcome these by trying harder during the meals. So that may be actually fatiguing your system even more. Okay, so this is something relatively new that we're seeing now, that we want to see how we can counteract that. Okay, now, how frequent are swallowing problems? And the medical term for that is dysphagia, so that you know if you want to discuss with your doctors as well. Dysphagia is very common in Parkinson's disease, depending on what study you read, but anywhere from 40 to 80% of patients. The reality is that most patients with Parkinson's disease or some type of Parkinsonian syndrome will probably develop at some stage of the disease some swallowing difficulties. The exact level varies, but typically that is common. Now, here's the trick, that about half of these patients are not aware of the problem. And there's a couple of explanations for this. So, and I've talked to many patients who come in and say, I don't have any problem swallowing. And by the end of the evaluation, we're finding that their swallowing mechanism needs to be worked on. They may not be aspirating massively, but usually the mechanism needs to be worked and practiced. Like, think about it like the rest of your body. What do you do for your arms and legs? You do rock steady, right? You do all these other programs. You want to keep your body as active as possible. Well, the head and neck is the same. Different types of muscles, but really also needs to be worked on in the same almost manner. Okay. One of the reasons why these patients are not as aware of the problems as well, the symptoms, one is that they come very gradually, and unlike the walking, swallowing is not obvious. It's in your throat. You can't see in your throat. You can't, tell for sure, right? When you walk funny or you walk, slower or whatever, people can see it. Somebody, even if you cannot see it, although you can usually, somebody will tell you so that you will notice it. With swallowing, it's not that easy. So that's one. The other thing relates to the sensory deficits that we see. So they may not be able to sense when things go down the wrong pipe as well. Okay, so they may not cough. So usually, for most of us, if something goes down the wrong pipe, we will cough right away, right? Patients with Parkinson's may not be able to cough. Okay. They may not sense it very well. Okay, so it is kind of a hidden disease, and I think that's why I'm glad to be here, hopefully to raise awareness so that you can start talking about this with your doctors. Because the reality is that in Parkinson's and in end late stage Parkinson's disease, unfortunately, not swallowing safely is most of the times the number one reason people get those respiratory infections and pneumonias, and they end up in the hospital because of them. So that's the number one reason why we have those respiratory infections. So the sooner we raise awareness and the sooner we can intervene, the better it is. So I actually want to show you, you saw all these videos before, the healthy normal, the healthy aging individual. I want to show you 4 different patients with Parkinson's at different stages of the disease. And I'm not saying that you will develop any of these necessarily, but the next part of the presentation is how do we prevent some of these and how can we work on this? But I want you to see what the differences are. So this is one of the patients drinking liquid. So kind of in a milder form patient. And the main issue, if you can notice, is a little bit of the liquid tries to trickle down the wrong pipe, but it never does. So he's doing actually pretty well. Okay, so this is in a milder stage. This is a patient swallowing something more solid, like pudding. Okay. And you will see that, this is a teaspoon amount of pudding. It takes 3 or 4 swallows. It's still there. We can even see some in her esophagus. So the esophagus is another muscle tube that gets, weaker as we age, and with Parkinson's as well. So again, safe, but the swallow is not as efficient, right? If you need to take for like a 1 teaspoon of yogurt or pudding, 3 or 4 swallows, imagine when you eat a whole meal, right? That's a lot of energy that you are spending. And remember, we saw from our research that you guys use your muscles more. So you are expending more effort even to do those normal swallows. And then in a little bit more advanced stages, you will see patients, clearly this is liquid. It's going in the airway. The person is not feeling it yet. When it's going to the lungs, he's feeling it, he's coughing, he's trying, But definitely we see some more airway compromise in this one. I'm going to play it one more time. This is liquided. So do you realize it shouldn't be stuck there, right? And it shouldn't be going to the front. That's the airway, okay? So this is, and this is a patient in moderate kind of stages of the disease. Yes?
Is that person aware?
So when it first went on in the airway, he wasn't, but then as it went down, he started coughing. Now, if this was a healthy person, as soon as the liquid started entering, they would cough. So they coughed, but a little bit later down. So they're not protecting their airway as well, okay? Now, they could also not cough. Some patients will not cough at all. And that's when the respiratory...
They feel it?
No, they do not feel it.
That's what I was just curious.
They do not feel it because that sensation is gone. So that's where it gets really tricky. And that's why I always tell patients it's good to get an evaluation as soon as you can because there are some things that are hidden. You will not be able to tell. Yes?
Is it a cough or is it a choke?
So a choke meaning like not being able to breathe. So with liquids, it shouldn't be a choke because liquids are so thin, they should go down in the lungs without making you choke. If people are choking, it's usually more with more solid foods, right? And we want to prevent that as much as we can, of course, because that's high risk for patients. But with liquids, it's very rare that somebody would actually choke, unless it's a very big chunk of liquid, right? Because to choke, that means that the airway was closed somehow, right? But that's a good question, though, because a lot of people say, I'm afraid to drink water. And I said, water is the healthiest thing to aspirate. So I almost never tell patients do not drink water unless there's other medical reasons. So you can drink water, even if it goes to your lungs. 80% of our body is water. The body will absorb it as long as you're active and you are, we want to be more conservative to patients that may be, in the bed or they cannot walk as well. But that's a good question. Yeah. Yeah. And this is a patient that actually has very severe dysphagia in the later stages of the disease. And again, I'm not saying that everybody ends up like this, but I want you to see how difficult it is. This patient is aspirating, they're not coughing, they're not feeling it, and they have a really, really hard time swallowing, okay? So this is still liquid. Yep. Mm-hmm. Now they're coughing. So a lot of times they will cough after we tell them to cough, too. Yes. Mm-hmm.
Regarding swallowing,
Mm-hmm.
how does that affect drooling?
Yeah, I will come back to that. Is it okay if I come back after I finish the slide? Just want to make sure we have enough time. Yes, but don't let me forget drooling, okay? There was a question about drooling. All right, yes, so we'll talk about that. So I just wanted to give you some, again, there's a big spectrum of different things here. In these situations, when it's earlier, we can intervene really well. We can get rid of these symptoms completely. So the earlier you come, okay, the healthier we can make the swallow for a longer time. When you come in these stages, it's a lot harder. There's still a few things that we can do, and some exercises we can do, okay? But a lot of it may be compensatory instead of actually rehabilitative to actually build the swallow back up. So that's the good thing that we're learning in Parkinson's. If you are, probably similar with things like body exercise. The earlier you can start, then you can keep it going for longer, and you can maintain your health and quality of life longer. It's the same that we're seeing for swallowing as well. Okay, so now how do we manage this? So for many years, the primary ways we were managing dysphagia, swallowing problems, were compensatory, okay? So things like changing the posture of when, if you do a chin tuck, for example, maybe the liquid will go down a little bit slower and it will be a little bit safer. Thickening liquids with thickeners. Who likes thickeners? Probably nobody. I don't know if you've ever tasted anything with thickener in it, but most of our patients hate thickening their liquids, okay? And I do not blame them at all. But as a compensatory strategy, sometimes if the regular liquids are too risky, thickening the liquid, especially in a temporary fashion, could make things a little bit easier for the patients and a little bit safer in the short term. Or using different devices like special cups or weighted or bigger handle spoons and forks to make it a little bit easier, especially with the motor issues that sometimes we see on the hand-eye coordination as well, hand-mouth coordination as well. However, the problem with all of these strategies, because they're just compensatory, they are temporary. So they're only as good as long as you use them in the best case scenario, or worse, in a very big randomized clinical trial that was done a few years now, more than a decade ago now. It was published in 2008. But it was a trial that included patients with Parkinson's and patients with dementia all across the country. There were multiple sites participating in this trial. And they did swallow evaluations on those patients, and those that were aspirating, which means that things were going down the wrong pipe in the lungs, they put them in one of 3 interventions for 3 months. Either an intervention that was just to use regular liquids with a postural change, or a little bit thicker fluids, or very thick fluids. And what they found was that those patients, the third group that were on the thicker fluids as a strategy, they had a 2-fold increase in developing pneumonia during those 3 months compared to the other groups. So thicker liquids are safer temporarily, but if you keep taking them for a long time, because you're not treating the swallowing mechanism is still problematic, right? It's still weak. Those thicker fluids end up sometimes in your lungs, and your lungs cannot absorb thicker fluids as well as they can absorb thin fluids, regular fluids, okay? So that's why we never want patients on thicker liquids for a long period of time without reevaluation of their swallow function, okay? So that was one of the seminal studies that actually showed us that. And also in the same study, they saw that of those who developed pneumonia, and had to be hospitalized, even the days of hospitalization to get rid of that pneumonia were much higher in those patients that were on the thicker liquids for long periods of time, okay? So bottom line, those compensatory strategies can be effective temporarily, but we want something better and more, right? So that's where rehabilitative treatments come in, and I'm going to talk about it next. So in order, though, to know how can we rehabilitate the swallow, we need to have ways to evaluate it to understand what is driving the symptoms, what is behind. So what do we need to do? We need to be able to measure. So those X-ray video swallow studies are very important because they're not only telling me if you are swallowing safely or efficiently. I can make a lot of measurements based on this to better understand why the structures are not working well and what part of the system is not working well. There's different exercises we can do if the mouth part is not working well, different if the throat part is not working well, different if the airway is not closing well. So there's different sets of things that we can do and target depending on what we see in those evaluations. In addition, we also have ways now to evaluate how strong your muscles are. So we have ways to measure how strong the oral muscles are as well as the pharyngeal, how strong the muscles under the chin are that are the primary muscles that help close the airway, and that's why we're interested in them. And we have ways to evaluate the respiratory system as well, and how effectively the respiratory system is working. And based on these evaluations, we can develop targeted rehabilitative treatment. And for Parkinson's specifically, there's 2 elements and trainings that we have been targeting. This is relatively newer, so most of this research is still in development and has been the last 10 to 15 years is being more and more popular, I would say. But remember, with Parkinson's, we said there's two mechanisms that unfortunately, impact the head and neck and the respiratory system. One is the coordination part, and the other thing is the reduced strength and weakness. So trying to address both is actually a good way to go. So individually, strength-based approaches that you may have heard of, one of the most efficacious treatments for strengthening the breathing muscles, as well as leading to improvements for airway protection, that reductions in aspiration, for example, for patients with Parkinson's specifically, is a training called expiratory muscle strength training. Let me see. How many of you have heard of this? Anybody? Okay. Great. Okay. This is using this small device. We actually have one of these devices up there if you want to come at the end and just take a look. And you breathe into that device, and you have to breathe up to a specific threshold for a small valve to open. That means you reached a target. And we can make the target harder and harder as your breathing gets better and better. Okay? So it's a resistive load device that helps with that. And we do see there is one recent study talking about drooling that showed that by doing this exercise, drooling also improved in some patients with Parkinson's as well. So there is some commonalities and effects across different systems in the oral and throat area. There is also training that we can do to strengthen somebody's tongue muscles and throat muscles, the back of the throat muscles. And for the tongue muscle strengthening that has been done, we have seen some improvements both in muscle function and in clinical measures. With the pharynx, because the throat muscles are a little bit harder to target, the results right now are mixed in those studies. But this is something that hasn't been investigated quite a lot yet. And then when it comes to skill-based approaches, which are more to target coordination between different parts of the swallow that need to happen. So for example, coordinating breathing and swallowing. When we swallow, the moment we swallow, breathing ceases, stops, right? For just a second to protect our airway, right? And right before and after, most of us would usually just exhale, and that's actually a protective mechanism. In patients with Parkinson's disease, sometimes after they swallow, immediately after they inhale. So why is that a little bit risky, you think? If after you swallow, immediately you inhale instead of exhaling, why is that risky? Yeah, so if anything is left in the throat, it could go in after the swallow, right? So it's kind of so patients with and it's not just patients with Parkinson's, we see that in other populations as well. So that coordination of breathing and swallowing is off. So now there are ways with biofeedback, you wear a small nasal cannula that controls your breathing, measures your breathing, and we can actually show you how you're breathing in and out and train you to exhale after the swallow with biofeedback approaches. This is an up-and-coming research and a very cool device that is being developed at Northwestern University by Dr. Bonnie Martin-Harris and her group. And it's actually, Bonnie Martin-Harris is actually a Purdue alumnus, so we're very, very proud of her and her work. Another motor coordination therapy that is coming out, and there's some evidence behind it. Again, these are relatively newer approaches, is an approach where you use those muscle reader electrodes on the skin here under the chin, and these are connected to a biofeedback screen or monitor, so you can actually see how you are using those muscles. And in this specific training, they train you when to increase muscle activity and when to reduce muscle activity. And remember, with Parkinson's, we see that people, even in normal swallows, they have increased activity because they try harder. So we could actually train them to use different amounts of activity with this type of exercise. And then, more recently, Dr. Trosche, who is our collaborator from Columbia University in New York City, she also has developed a new training to improve cough. Because cough is important because patients with Parkinson's have reductions in effectiveness of cough and in the strength of cough. So she has developed a program where we can actually, again, use a small device, and we have one there that you see here, and we have one there on the table that you can take a look at later. You learn to cough at different levels on that device so that you can strengthen and make the coordination of cough and airway protection a little bit better. So all of these studies and programs and the effects that I've talked about are about the individual programs by themselves. Now, it makes sense that if we try to combine some of these treatments in a way that hopefully doesn't overwhelm the patients and improve access, it will hopefully make things better for patients. So this is what our work has been trying to do. We have been trying to take some of the already known and efficacious treatments and combine them together to make things maximally effective for patients, and then develop some devices to help with making these treatments more accessible as well. So one of our projects, and some of you, I don't know if in this group, but several people from India also came to Purdue and participated, is a project that we use one of the wearable sensors that we have developed, and I showed you a picture before, but you'll see it on the next slide as well, that goes under the chin. And in this study, we were interested in trying to combine both strength training of the muscles that protect the airway, but also how well the airway can be protected, so coordination training together. And we use this new technology because the ultimate goal of this technology is to be used at the home setting by the patients, so they don't have to come into clinic all the time. So this is what it looks like. It's called the iPhasia. It's a small little sticker that goes under the chin, okay? It's connected to through a Bluetooth, through some cables to this Bluetooth device, wireless unit. And through Bluetooth, this device talks to a software. And right now, here you see a phone. Right now, it works with a computer, but ultimately, it will work as an app on your phone. And the therapist is at the clinic. So you can be at home and doing the exercises using this device. And the therapist can get access to the data while you're doing the exercise, so they can provide feedback to you. They can change the target of the exercise if you're not doing well one day. But you also get feedback simultaneously as we are doing the exercise. So we actually had patients, because this is under development, so we had 15 patients with PD that came in just for one session. We wanted to see how well it worked, how well it adhered to the skin, if people had issues with satisfaction, any adverse effects, how well it worked. And we also said, okay, why don't we also evaluate them before and after the session? I know it's only one session, but could we actually see some changes, either improvements or not improvements? Maybe we're tiring them out. And it was a pretty intensive session, 45 minutes. They swallowed about 60 times, 32 different sets of exercises that they did. This is what it kind of looked like when they, what it looks like when you put the sensor on, so you get an idea. And actually, we have developed methods so that, and we are developing, we're optimizing them so that patients can hopefully do that by themselves without us necessarily. And then there's the software, the Tele8 software, that will open up, and the patient will be able to see how much effort they're putting when they swallow, but they can also see some timing parameters so that they can work both on strength and coordination with the appropriate feedback. Okay, let's see if it's, and you can actually kind of see as they are swallowing different bars going up so that they can get that feedback in terms of how much effort they are putting, for example. Yeah, just to see kind of an example. So the good things was that post that one session, overall the satisfaction was pretty high. We did not see any adverse events that made us worry. And we saw that the patients were able, their swallow movements, so how well those structures in the x-ray moved, they moved better, but with less muscle effort. So this is showing you muscle effort. So the before and after for all of the patients for many different tasks. And across different tasks, there was a reduction. Now, this is very small scale, but it's only one session. So even in one session, we can make the swallow structures move better, but the muscle effort required less. What are we doing? We're making the swallow more efficient, right? So this is very, very good news. So we're very excited. We're writing it up right now because it's the first time that this has been shown that with one treatment session, you actually can see those improvements right away. I thought, for some people, we may be inducing fatigue, potentially. But so this is actually promising. Now, this was 15 patients, not big, and it was a feasibility study. But the next part is actually, which is our new NIH-funded study. I'll finish and I'll give you the word. We're actually now using the system in this biofeedback trial that will be a 12-week treatment protocol. There will be 3 arms. One will use the device and the protocol at home group. Another group will be coming to clinic to use it. And a third group will be doing the exact same exercises without the device. Because we want to see, is it the device that's making the difference or not, right? If we show that the device is effective, then for the group that didn't get the device, we will offer free 12-week treatment with the device after. So we will give to them. So if people are randomly assigned to the no device group and they feel cheated, they will get the device if we find that it works, I promise. We just have to do it so to make sure that everything works. So it's starting in spring. We're actually now in communication with NIH because we need to have the data safety monitoring board and they have to approve everybody. So we are in the planning stages, but it should start by early spring. And there was a question, I think? Yes.
Yeah, I just mentioned, we talked to you at
Yeah, the moving day. Yes, yes.
and so we like what we heard and want to get involved with that. But another question I have is, and I know it's not the right terminology,
Mm-hmm.
because I call it speech therapy.
Yes.
And so part of that we're doing with that is that we're actually intentionally speaking, thinking of what we're saying, speaking out loud.
Yes. Mm-hmm,
So that
mm-hmm.
that's strengthening the muscles is what I understand.
Yes. Mm-hmm, mm-hmm.
And then some of it, there's different practices of what you do there from speaking loud.
Yes.
To doing those kind of things. Now that, I'm like target. what
Yes.
you're talking and-
So thank you for asking that question. So the question was about do treatments like the Speak Loud and LSVT, loudness treatments that focus on speech and voice, do they have an effect on swallowing? Is that so? There is a little bit of research in that area that shows that actually people that did some of those treatments had some small improvements in swallowing as well. It makes sense because the same muscles, right, and nerves are used differently for voice and speech and swallow, but the same structures and muscles are used. The problem with those is that compared to some of the exercises that we're talking about now that we use with these biofeedback devices, is that you can plateau really easily, right? So because you can be as loud, for some period of time, and that will have good effects on your voice, but the swallow, because the swallow is not specifically worked on, and how the muscles are used in the swallow are a little bit different than voice, you don't get those effects for swallow, not as strong effects and not as long-term effects. So some of these exercises that I'm talking about are specifically targeting them muscles groups that we use for swallow, and by using the biofeedback, the good thing is that you know what to target, and then you can always up that target, up the target, up the target, until you reach the point that's your highest level, or the most functional level, hopefully. Does that make sense? So there may be some effects on your swallow, but by itself, it won't be enough. Does that make sense? That voice therapy, yeah.
But that would make a difference in your speech as far as where you have, we can't.
I think the question
Yes.
is if you do
Some of these,
exercise in the swallowing,
Yes.
have you seen improvement with people's,
voice and speech.
yeah.
So I will say probably not with these that are more swallow specific, but the next set of exercises I'll talk about are the breathing and cough. Those you can definitely see an improvement in voice as well. And there is some data on that, absolutely. Yes, so depending on what mechanism you are targeting, yes. It's it's not one-on-one. It's not like you definitely do this and you will definitely see improvements in the other one, but you may see some carryover, yes, yeah. Mhm.
Have the participants for this study been
Yes.
selected?
No, we're just starting. So it's going to be open enrollment very soon. Yeah, yeah. So if you are interested, you can definitely sign up so we can be in touch. Yep, yep. So I want to say, but I want to talk about another study that is going on right now. It's also NIH funded, and it is in collaboration with my great colleague at the Columbia University, Dr. Troche. And this is a study that now also combines strength and skill training, but now for the respiratory and cough muscles. So it's a little bit different. But those muscles, especially for Parkinson's, and this is specific to Parkinson's. The wearable sensor study is Parkinson's and stroke patients, so we're recruiting 2 populations. For this study is specifically for Parkinson's patients only. And the nice thing about this study is that it has 2 phases. The first phase, what we call the intense phase, is 4 weeks. So patients, if they qualify, they come in, we do a full-blown evaluation of their swallow, of their cough, their breathing, the most comprehensive evaluation you can find in the US on these functions. And then if they qualify, they get 4 weeks of intense treatment. By intense, I mean they do their exercises every day at home, but we see them once a week. Then they come back at the end of the 4 weeks, we reevaluate them. And if they made gains, and if they're doing better, they have the choice after that to also participate in the phase 2 of this trial, which is a maintenance phase. So they have the opportunity for a full year to keep the devices, keep practicing, and then we see them once a month if they do the maintenance phase. That's completely optional. They don't need to do both. They could do the intense and then come back and do the maintenance or not. It's up to them. In this study, we have 2 groups. One, all the treatments are in person, so they would have to come to Purdue. I know a lot of people say no. Okay, once a week. But there's a telegroup, a telehealth group. So if you are randomly assigned to the telegroup, you only need to come for the evaluation data points, but not for the treatment. So this is just the schedule, exactly what I just said with more details and approximately how much time things take for the intense phase. And there is compensation for all the evaluation time points, but not for the treatment. So there is payment that we provide to patients. And this is for the 6-month or 1-year maintenance if people choose to do that second phase as well. So in this study, we want to see, we already know that we're combining the expiratory muscle strength training that I talked about, the EMST, with the cough skill training that Dr. Troche has developed. We know by themselves those 2 are effective. So it's the first time we're combining them, so we want to see if they're combined, they're even more effective. And then we also want to see if telehealth is as good as in-person treatment, and if 1-year maintenance helps with maintaining gains. So these are the 2 treatment studies that we have right now that I wanted to focus on for Parkinson specifically. And then I just want to take 2 minutes to talk about a 3rd study that is not a treatment study, but we're very, very excited about. And it's not only about Parkinson's, but I think it's going to change the way we evaluate swallowing and hopefully treat it in the future. This is a diagnostic study. So this is a study where we have been developing an MRI sequence. Everybody knows what MRI is? Yeah, I see a lot of nodding, and some of you have had MRIs. So we're developing an MRI sequence that will allow us for the first time to look at the muscles of the head and neck as people swallow and the brain activity at the same time. So we'll be able to tell exactly, with very high specificity, what is happening at what stage of the swallow for both healthy people, but also for patients with neurologic issues. And we're hoping that actually we're going to be able to predict and develop some biomarkers based on that sequence that are going to help predict progress of swallowing for patients with neurodegenerative disease. So this is a really big deal. This is also funded by the NIH. We're very, very excited. So right now there's 2 separate procedures, right? The X-ray I talked about, and then the MRI of the brain that people can do, right? But there's no direct information about how the 2 work together. So this is what this looks like. And Dr. Brad Sutton is our biomedical engineer from UIUC, who is the other PI. We're the 2 PIs in the study. We developed this scan together. So this is what it looks like. So the person swallows, and they're in the magnet. We actually, I don't know if you can see these little crosses, so we can make a lot of very detailed measurements as they swallow. Then at the same time, the reason why you see this being fuzzy is the brain is being imaged at the exact same time. So we can get really good information about both the swallow and brain function. So really, really cool. And we're actually now just validating. This requires just 1 visit in our lab you would do a regular swallow study and then that one, and we then make measurements and compare the two. And for this study, we are, again, there's compensation, and right now, because we're validating, we are actually starting with healthy young and older adults. So if anybody is interested, let us know. But also, we're planning to look at stroke and Parkinson's patients at different levels of severity to test the biomarkers. That's kind of the third aim of that study. Okay, and with that, I just wanted to let you know about some of the very exciting things that are happening here. I do want to just make a couple of summary points, and then we can open it up. That, swallowing difficulties are common in Parkinson's, but can be improved with targeted treatment. So this is something that you should be talking to your medical doctors about and neurologists and asking them about it. And I personally believe, and I think a lot of us in the field believe, that patients at all stages can benefit for this type of treatment. And as with everything else, it's better to be proactive than reactive. If we can be proactive, we can actually, slow, make the progress of the issue slower and maintain quality of life and pleasure with eating, which is so important for as long as possible. So now we can open it for questions.
Any questions?
Thank you. Yes.
Hey, I have a question on this rehabilitative
Yes.
Intervention.
Mm-hmm.
How would somebody go about getting that?
You-
Do you ask for a referral? Or
So you would need to be evaluated first, right, by a speech pathologist typically. So speech pathologists evaluate swallowing. Definitely in the state of Indiana, I believe that's true. And in other states, there may be a couple of other professionals. So you would need to talk to your neurologist and ask for a referral for a swallowing evaluation. Now, if you go to your neurologist and say, I don't have any swallowing problems, and say, but I want a referral to a swallowing specialist, they probably will not give you one, unfortunately. But I think more and more neurologists are starting to understand the importance of being proactive and at least getting a baseline assessment early in the disease process. And it may be that people are, their swallow is functional, and we'll tell them that your swallow is functional. There's nothing right now, that you need to absolutely be doing to make the swallow. Your swallow is safe right now. Mm-hmm. The issue is, if you want to be proactively working on it, it's good to advocate for some of these types of treatments earlier on.
Yeah, because
Yeah.
you mentioned that even like mild.
Yes. There's changes
usually
happening.
There's actually
Yes.
changes happening.
The problem with that sometimes is that because the regular, if you just do the X-ray, which most speech pathologists will do, if you do not aspirate or have any residue, they will say you're fine. And you are fine. I'm not saying you're not fine,
Right.
but I'm saying let's be proactive if we can. Does that make sense? So it may not be as easy to get to the rehabilitative part earlier in the disease process unless you advocate really hard for yourself.
Yeah.
Does that make sense?
Yeah.
Now, if you are at a university place with university clinics, we offer a lot of programs, a lot of them free. And I know, probably IU Bloomington, other places may offer different things like that. So that's one way to try and be more proactive, but also advocating for yourself early. Say, I want an evaluation, and and hopefully, and then advocating also, and sometimes educating your therapist that I don't want thinking liquids. I want something more. Can we do something more than just compensatory? If they're pushing compensatory strategies, sometimes it takes educating the therapist as well. But evaluation, the first part of the evaluation should be done first, because then after the evaluation, in order for treatment to be effective, it has to be targeted, right? So that's why we need the evaluation. We need to know what parts of the swallow have been affected, so that then we can say, okay, these are the things we need to target in treatment.
Now, do you do the evaluation?
Mm-hmm.
You mentioned several studies you
Yes.
guys are doing. Is that evaluation included in?
Yes, see, all treatment studies have pre and post evaluations, at least 2 time points, sometimes more.
Oh, so
Yes.
That'd be a way to get it.
Absolutely.
Yeah.
I mean, a lot of times I'll tell patients, even if you don't want to do the full study, come in for an evaluation. You get a free evaluation. It's the most comprehensive. I mean, I know I'm sounding like a salesperson, and I don't want to be. And we would love to see all of you if you wanted to come. But we offer, the reality is, and I hope I'm not sounding arrogant, the most comprehensive evaluation you can get in the state of Indiana.
Well, yeah, and I mean,
So-
it seems like the least resistant way
It is.
evaluate
It is. It is. It is.
without having to expend all
And the other thing also we do give you the videos of your swallow study. So if you wanted to share them with your neurologist, you can. There have been times where patients were like, I don't have a lot of issues. They came in, then we identified some issues. We sent the videos to them. They shared with the neurologist, and the neurologist said, "Go and do that trial." So that the neurologists themselves identified, this is a good way, go and do it, because they saw that they were starting to have some problems. So I just would not wait until, you're coughing or choking. Don't wait until that point. That would be too late. We can still do a few things there, but it won't be, if you want to be, I would say, the earlier you can, be proactive. It's the same as rock study. Be proactive early, right? And for as long as you can. But starting early, I think it's the same as whole body exercise for all of us, right?
Thank you.
Yeah, yeah.
We need
Any-
to watch our time.
Oh, yes.
More questions?
I think there was a question about drooling. Should I yes, and then okay. So I just want to mention about drooling. So unfortunately, in Parkinson's you can either have drooling or the opposite, dry mouth, right? And that can be really tricky. A lot of it is the medication, unfortunately, side effects, or it could also be that the frequency of your swallow is reduced in Parkinson's. So for example, most of us, we swallow our saliva once every couple of minutes. Otherwise, we would drool all the time, right? And we don't. We don't even realize that, but that's what we do all the time. With Parkinson's, you swallow less frequently, once every 4 to 5 minutes. So then if you are producing all this saliva and not swallowing it, it can cause drooling, unfortunately. In addition, with the muscle weakness in the face, that can also add to it. So we don't have very good behavioral treatments for that. The one study I showed you with that breathing aid device is the only one that we have had some success with reducing drooling as well, but not significantly. So most of the times, if drooling is a big issue, we ask, from support of the neurologist to prescribe some medication that can help a little bit more with drooling. So it's more medical than behavioral things that we can do. And there are some pretty invasive surgical things that can be done as well. But again, that's a discussion with the neurologist. And unfortunately, we don't have very good behavioral ways to treat drooling. Not yet. There's a few people working on some devices, like suctioning devices that are portable. But the ones that are now available are not things that people would want to go out and and be in the community with a small device like that, and so they're not, the prototypes are not that good yet. But lots of people are thinking about that and working on that, though. Yeah. So I would say medical and surgical, unfortunately, are the more effective. Yes. Oh, yes. Yes, Scott. Sorry. Yes.
The broader question.
Yes.
in a way. I remember I was diagnosed 25 years ago.
Yes.
And at that time, there was a lot of concern, and it was represented by Michael J. Fox Foundation, that there would be a lot of duplication of efforts between doctors and clinics and so on.
Yes.
That are seeking recognition and all those things that go with it. And Michael J. Fox shifted his vision to less than $10 million is raising. It's good money, but not really good when you put
Yes.
this. So he shifted into collaborative mode and trying to foster that. My question is, I hear you talking a lot about collaboration
Yes.
that you have across the country. Is that serving do they do a better job of collaboration? Do you feel that you have access to other people that need to be there?
I think that's a great question. We absolutely, in order to be effective in a lot of these things, it definitely takes a village. It takes, all of us to sit on the table together. I wish we had more collaborations. And, the funding agencies like the National Institutes of Health definitely wants us to collaborate more, but they don't necessarily make it easy either. So, and a lot falls on the investigators themselves. The reasoning has been, they're just too busy, and I understand that. But it has been very hard. Finally, I have one neurologist from IU now and one speech therapist from IU that are going to be helping us in one of the studies recruit patients. So it has been very difficult to collaborate locally, and I don't know why that is, because I have approached so many people since I first came. Now I've stopped, to be honest. Like, I tried really hard the first 5-6 years I was here, and now I'm like, you know what? I can do this at Purdue, with my collaborations from other places, It has been really, really hard. So I don't know if it is the IU Purdue thing, if it is really a matter of, how busy everybody is. So collaborations are very important, but unfortunately they're not as easy. So I hear your point, and I wish we could do more. Yes?
What about Ball State University? Do you ever collaborate with Ball State?
We haven't.
You
Yes.
need to.
I know. Yeah, we can think about it. Yes.
They have the Parkinson Voice Project. I've got Don's
Yes.
card I will give you.
Okay, that would be great.
We have a Parkinson's program in Muncie.
Mhm.
And we're seeing more and more people attend that are Ball State faculty.
Mhm.
And they participate now in Rock City. We just started that.
That's great. That's great.
And Ball State's
Yes.
Speech Pathology Lab
Mhm.
has a lot of things going on as well. So we just need to make sure you guys know.
Yeah, we can connect. Absolutely. And we would love that. Yes. Yes.
Yes.
I think there was one more question. Yes. Sorry, John. I know. Are we eating the time from the auction? Yes. No. Go ahead. One question.
Regarding swallowing and drooling,
Yes.
what about the chewing gum as a behavioral?
Yes. As a behavioral treatment. It probably temporarily it could help, right? Because it reminds you to swallow more, but at the same time you produce more saliva when you chew. So it could be intuitive a little bit, or counteracting each other. Chewing gum by itself because people ask that question as a potential exercise, because it is not, it's a functional type of thing. And you will reach the skills of the chewing gum really quickly. It won't really do a lot beyond like a few times you use it, right? So it won't help keep building your muscles. But for drooling, unfortunately, because you will be producing more saliva with gum, and I'm not sure that you would actually be swallowing more frequently. You can try it, but not super effective, unfortunately, for most people. Yeah, it's a good idea, good thinking, but not as effective, unfortunately. Yeah.
Sometimes
Yeah.
people swallow with their tongue between their teeth.
Yes.
And it seems like if you chew gum for a period of time as exercise, and then you swallow it intentionally by putting your tongue between your teeth,
Mhm.
that might be an exercise worth doing.
Yeah, that's more for tongue shaping and rest, exactly. So that has to do more with speech than with swallow. So yeah. So yeah, but I can do that. Yes. Yes, I think we are good. And I'll stay for a few minutes if you. Unfortunately, I won't be able to stay for the whole thing, but I'll stay for a few more minutes if you have more questions. And if anybody's interested in any of our work, please feel free to write down your names and we can contact you.
In fact, we're going to take a little break here, and please
Yes.
visit the silent auction table
Yes.
and the vendors, and then we'll.
Yes,
get around.
absolutely.
I am pleased to have Rhonda Ryan join us today. She is a facilitator with people with declining abilities. I just don't want to say memory and other things, it's everything. And she has come and tell us a little bit about your credentials, because you've been in the business for 24 years, right?
Mm-hmm.
Okay,
Yep.
thank you, Rhonda Ryan.
Can I mention where I'm from, where I work, or would you rather I didn't?
It's okay.
Okay.
It's okay. Yep. if we're snarled or. Nope. Houston, we have a problem.
There we go.
Okay, there you go.
Yeah,
Thank you.
there we go. Now, it's a corded mic, so it'll probably only take about 5 minutes before I trip and make a fool out of myself, but here we are. I'm Rhonda Bryan. I'm the Director of Memory Care at Hoosier Village. I have been in the retirement community for 24 years now. When I was finishing up my degree at IUPUI, I had an opportunity to do an internship with the community, and I absolutely fell in love with the population. And if you visited that community, you know it's also a beautiful setting, so it was kind of a double whammy for me. I have been through several positions there, but most recently have switched to the director of the memory care, which is an exclusive, secure building for people with cognitive impairment. It is licensed at assisted living, so like many of you, they are very capable of doing things for themselves. And throughout that time that I've been there, I've explored a lot of opportunities, but mostly with cognitive impairment and then what the caregiving role is with that. So before we get started, if you are a person with Parkinson's, would you let me know who you are? Okay. Who is a spouse or a life partner? Okay, good. Any children here? Friends, co-workers, somebody from the church that helps to support a person with Parkinson's? Okay. Well, today we're going to look at what it takes to be a care partner. And so, sometimes in the role of care partners, we forget just how awesome we are, because it takes a lot of work. It takes a lot of patience sometimes. It takes a lot of learning, and it's scary work, right? So thanks to Supernus, they sponsored this. Each person here has a little notebook just to remind you how awesome you are. So if you didn't get one, let us know and we'll get one to you. The other thing I've given you is a sheet with some positive affirmations, and these are things that I'm going to kind of bring up throughout our talk today. And I was going to have you write them down, but I figured it might be easier if I just put it out there for you. So our care partner journey begins, right? So first, let's look at what a caregiver role is. So a caregiver is that person that supports another with their basic needs, right? So if you work in a nursing home environment, or if you are a spouse of a person with a debilitating disease process, the parent of a child with a disability, and you're doing caregiving, you're likely doing at least some of these, and maybe not all. So we're looking at hygiene care. Those can be things just, bathing, showering, grooming, your daily care needs. You can be helping with medical care, such as managing appointment schedules, advocating for the healthcare system. As she was sharing with us earlier, sometimes that's kind of difficult when you're trying to get referrals into different areas. Sometimes that caregiver's role is to help with that. Medication management, so maybe that's the person that sets up your med minders for the week. And maybe that's a person that's there all the time. Maybe it's a child that comes in and helps with those things. Transportation. There's nothing more awkward than that issue or that conversation about it's time to stop driving, right? That's a hard one. That's giving up our independence. And sometimes those frustrations cause some of the issues that we have between ourselves. Meal preparation, that could be basic nutrition. When you talk about the issue of how long between medications and meals, managing all of those different things, cooking, even the simple things that we take for granted, like grocery shopping. Mobility, that's not just getting from here to there. It's not just making sure that we have the cane that we need or the new walker or a wheelchair. Sometimes it's as simple as, how do I get out of a chair? Emotional support and companionship. Our household chores and home management, those are all things that a caregiver may take part in. Eleanor Roosevelt said, you must do things you think you cannot do. Has that been true for any of you so far? Okay. Who are caregivers? Well, nearly 1 in 4 adults are caregivers, and that's providing regular care for a family member, a friend, or somebody with a health problem or disability. About 50% of that work is with personal care, and about 80% is household tasks. Nearly half have provided care for at least 2 years. Almost a third provide care at least 20 hours a week. Of those, about 60% are women, and 18% are 65 or older. 38% are caring for a parent or a parent-in-law. Over half feel like they don't have a choice, but a lot of times that lack of choice is self-imposed. It's because our role in the family. 43% feel it's their responsibility because nobody else can do it. So perhaps it's a child stepping up because there isn't a spouse in the picture anymore. 12% feel pressured from the person needing care. You know, over half are still working at the time that they're providing care, and about 70% of those folks report some work-related difficulties due to their dual roles, trying to manage appointments and getting people to different things that they need to get while working full-time. So what's a partner? We're looking at the care partner role today. What's a partner? Well, a partner is a person with whom someone shares an intimate relationship, right? Spouses are partners. But they're also two persons who dance together. And after all, life is a dance, right? One or two or more persons who play in a game. So, and in this case, they're on opposing sides. It's the disease that they're opposing. One associated with another, especially in an action. So our military partners throughout the world, we are a united front in this process. A member of a partnership, especially in a business. And aren't our households a business? We're paying bills, we're managing, making sure that everything stays on track. So that becomes a business in itself. But one of the things I liked the best was the last description in the dictionary, and that's one of the heavy timbers that strengthens a ship's deck to support a mast. And that can be you, the caregiver. It takes a lot of strength and a lot of courage some days to be a caregiver for someone with a chronic illness. Now, I looked again to see, well, what's a care partner? So I typed in the word, and this is what I got. The good news is that means we get to make it up as we go along, right? Because it's not in there. So who are you? We kind of talked about that a little bit a few minutes ago to see what roles we are all playing in this process. How often do you provide that support? Now, being that most of you here are a spouse, you're probably living in doing this full time, right? But sometimes we have frequent or occasional supports. That might be the child that comes in and sets up meal management or some other services for you, sets up medications once a week, takes you to appointments, but it could be kind of frequent, or it could be somebody that sets up things from afar. Some of us have children that live in other states or other areas that need to be a part of this process. Are you enough? Yes, you are. Because even sometimes when we feel like we're not, just being a part of this process and being there for another person is. Before Parkinson's came into your lives, did you have difficult days? We all do, right? Did you have some days that it felt like life was out of control? Of course we do. Especially if we're raising kids and we've got a full-time job and you're trying to pay the bills and all those things, life kind of gets crazy sometimes, right? Did you feel overwhelmed or feeling that you were not quite adequate sometimes? Those are feelings we all have. They're all very natural. Martin Luther King said, "If I cannot do great things, I can do small things in a great way." This is particularly true when we don't feel like we're being all that we can be. Sometimes we have to stop and back up and realize that that small steps really do matter. Now, for those of you who are married, life changes. This has been your best partner or your best friend and your partner in life. Together you've established a home, you're running this business of a household, you've provided and supported each other. Sometimes those things were things that you worked on together. Sometimes you each had different roles that complemented each other. It's an intimate relationship, both physically and emotionally. And sometimes we see changes in the abilities of the functional abilities with intimacy. You have shared memories, dreams, and plans. And sometimes diseases like Parkinson's or other diseases, dementia diseases, rob us of what those plans were, don't they? Doesn't mean they can't be great, though. The changing role from child to caregiver, for those of you who have children, our parents are the people that we look up to. They're our role models. They are the decision makers of the household. They were responsible, they were strong and fearless, and they provided for everything, our support, our emotional support. Now, they may become more dependent on us as children to support them. And I can tell you from working in this environment for a long time that the role from being a child to being a parent of a parent can be very difficult on both sides. Children have difficulty taking on those responsibilities because they don't want to be involved in your finances and making decisions for you. The parents a lot of times are very reluctant. There's a condition called anosognosia, and that is that for a while you can recognize the disease process as a person with a dementia diagnosis. You recognize that you have Alzheimer's, or you recognize that you have Parkinson's. And you may start to recognize some of the symptoms of the dementia that may come with this, or Lewy body disease. And you can recognize that for a while, and then suddenly, or eventually, you no longer recognize that for yourself. So everyone else that's helping to provide care for you is well aware, but you no longer have that ability to recognize that. And that can be very frustrating for you, but also for your family members as they try to, give you reasons why you need to do things, or the help that you need, or the reasons that they have to help make decisions. That can be very difficult. So what, as a caregiver, are some of your personal characteristics? So as a caregiver, raise your hand if you are a nurturer, a caregiving type person that nurtures, right? Now, most often, this is women. If it's children, most often it's the eldest daughter that kind of takes on the role of being the nurturer and the supporter. Are you a problem solver or a fixer? A lot of times this is a male role. They've always repaired things and fixed the problems that have gone on in the household or in the business. There are a lot of us strong women out there that fix a lot of stuff, isn't there? Do you enjoy being the life of the party? Anybody outgoing likes to be right out there doing things? Okay, how about, would you rather remain invisible? I'm going to guess, since nobody's raising their hand, you're all invisible right now. Are you able to delegate? Okay, got any delegators in here? Or are you the kind of person that has to do things for yourself? Right? If I don't do it, it won't get done right. Are you detail-oriented, organized, kind of structured with your daily routines? Okay. Are you easily frustrated when you become overwhelmed? And own it. Are you a taskmaster? Must you work feverishly until it's done or until you collapse? Everything has to be done in its place, right? Or, now this is the important one, are you cool, collected, easygoing, work at a steady pace? If it doesn't get done today, it'll get done another day. Now for those taskmasters in the room, look around. These are the folks you need to line up with so they can tell you how to do it. The world is better with you in it, regardless of what your personality type, regardless of how you function through the day. It takes all of us because we're all very unique and special. The person with dementia or with Parkinson's Are they quiet and reserved? Have they always been a person that was able to delegate? Are they a strong-willed person? We look at all the same things and recognize in this process that each of our relationships and how they work is because we're all unique individuals. The strengths of one balance the weaknesses of the other until we make a good union. About 50% of people with Parkinson's will have some decline in cognition or thought processes. Many will develop its own dementia. We typically look at the working memory. It impairs the ability to do familiar tasks or retrieve information. You may experience difficulty with attention, concentration. Mental processing begins to slow. It's not just your muscles that are becoming more rigid and slow, but sometimes the mental processes follow suit. Hallucinations and delusions. There's a thing called misperception. So I live between Terre Haute and Bloomington. On my way home, I go out 70 and then I drive about 20 minutes out in the country to get home. Beautiful drive, right? And so as I drive, I see a lot of animals, deer, dogs, rabbits, all kinds of things. And one day it's kind of getting dusk, and as I'm driving, I see something that, in the distance, it's like this, right? So what do I think it is? Anyone? Deer, especially right now. So I start to stop. Well, then I figured out it was a mailbox. So I could immediately go on, right? A misperception for a person who is not having any difficulties with those parts of their brain is going to be able to do exactly what I did. They're going to be able to step on the accelerator and proceed. A person who has delusions or even hallucinations, once they see something like that, it becomes much more difficult to change channels and go back. So when they see somebody standing in the corner that they don't recognize, they may feel like it's somebody that's there to do harm. When they see that old man in the mirror looking back, it's not them, right? It's somebody who may become scary. So these delusions may become a difficult part of the process. Sorry. Problem solving, such as planning, organizing, and completing tasks. When we talk about organization, we're not just talking about how tidy your workspace is or how tidy your home is. We're looking at how you organize your day. Can I get my clothes on in the right order? All of these kinds of things take organizational skills. And then lastly, language. Sometimes folks have difficulty finding the right words. Sometimes they may have a whole conversation, but none of the words kind of go together or make any sense. And sometimes that becomes more difficult when they're under some kind of stress, or when they're in public, or when they're at a dinner table with friends and family. It also affects mood. We may see a lack of motivation and interest in doing things. There may be uncontrollable worry or anxiety. They may have feelings of hopelessness, sadness, and loss. And then there are the sleep disturbances. And one thing we know is that mood affects sleep and sleep affects mood. If we're extremely tired, we may be a little cranky, right? If we're having trouble sleeping because we're frustrated, then we're going to have trouble sleeping. Becoming a care partner, first recognize that each relationship is unique, because everyone in here is a different person. Their approach and their gift to their relationship is going to be different. It is based on your relationship. Are you willing to still be a partner in the dance when it means that you as a care partner are now the leading person instead of the person who's on the other side? Are you able to face those challenges and work through them because you know you can? You know that each day is new and you need to start over again? Do you have the strength to be one of those heavy timbers for your relationship? I couldn't help it. I had to do that, right? Relationship. Optimism is the faith that leads to achievement. Nothing can be done without hope and confidence. And that was from Helen Keller. If she could have hope and confidence, can't we all? Some caregiver traps that we sometimes fall into: denial. It's not being able to admit the truth or the reality of the disease process. We become focused on a future with dread. So we're dreading every new nuance throughout the disease process. Diagnosis triggers negative emotions, and mutual stress can cause relationship issues. The future as we planned is lost. We have to navigate a new future for us. Our brains automatically pick up the negative in a situation. Positive has to be purposeful. So as you're trying to deal with new situations in your relationship, it's automatic to think of the negative parts of what the outcome may be. Sometimes as caregivers, we go into autopilot. As soon as we assume that role as a care partner, we turn the person into a patient and we become the nurse. And what we do with that sometimes is we start doing for people what they can still do for themselves. So we take away their personhood. My mission is not just to survive, but to thrive. And that's on both parts of this relationship, isn't it? It's not just the person with Parkinson's, it's also the care partner. Some things to do in the early stages of your disease process, education. Education is key. Attending doctor's appointments together. And what I like to say is take this notebook or another notebook. Before you go, make notes of things that are changing. While you're there, take notes of what he's saying or she's saying. Because you'll get home and a week later, some of the things that were said or some of the suggestions may not be something that you can immediately retrieve. Handling business transactions, so bill paying, health insurance, how are you going to handle those together? And how are you going to handle them as things change? Create safety net for future cognitive losses, such as additional signers or putting together your advance directives. Letting your family know what you want. What do you want as far as resuscitative measures? Who do you want to handle finances when you no longer can? Or when your spouse can no longer do that. If your spouse is your caregiver and something happens, then you need to, it would be helpful to have those things done in advance. Dr. Natalie is a geropsychologist, and you can YouTube her videos, and she's excellent. They're like 5-minute videos, and they have all kinds of helpful things. She put together these 4 R's, and that's as for calming distress with your partners. Reassurance that you're here and you're not going anywhere, and together you can figure it out. Reflection, and that's sharing how your feelings back to them. So when somebody's frustrated, you feel their frustration. You're empathetic with that. Redirection. Sometimes in frustrations, we need to get off of the current subject and go on to something else. And sometimes we just need to walk away. Do you ever need some space when you're frustrated about something, but you have somebody that just keeps asking you questions? They're wanting to fix it and they're wanting to help, but you just want them to leave you alone, right? So walking away. I'd add a 5th R to that, and that is recognize that you're human. That every decision you make, how you care for help your care partner today, may not go as well as you'd like, but tomorrow's a new day. And by saying that, don't let yesterday's mistakes weigh too much into today, because every day is an opportunity for a fresh start. Some don'ts with your partner as the disease progresses. Don't constantly be everything about the disease. Nobody wants to hear how much help they need from another. Sometimes our care partners in long-term care will walk into a resident's room and say, I'm here to help you, or you need help with. And that's not the right approach, because we don't want to hear the help we need, right? We sometimes don't recognize that we do, and that's just frustrating. Don't correct or argue. That's hard. That's real hard, especially when it's factual stuff. But sometimes when we think about it, those facts really aren't that important. So save something for another day. Don't make everything about caregiving, and don't make everything about them as the patient and you as the caregiver. Serena Williams said, "A champion is not defined by their wins, but how they recover when they fall." That's a good thing to remember, that once we get back up, we get started over, and we get a new try at it, right? Because every day is a new day. There are difficulties with relationships with other people sometimes. So our friends sometimes kind of drift away as things become more difficult for us. They may have noticed changes, but if we're not really talking about it, it's kind of that elephant in the room. Are you embarrassed by what your friends might think? Are you kind of still in denial of the disease process? There are some pros and cons about sharing your diagnosis. For one thing, if you share it with your friends and family, you may get a lot of emotional and physical support. Understanding changes they have already been seeing, now you've given an explanation that they can understand. Planning for the future, that's future care needs, legal issues. Sometimes it gives it the opportunity to reduce the stigma of the disease. It may provide access to resources through networking. As you're talking about it to your friends, they may know someone, or, for example, the studies that she shared with us this morning are things that you wouldn't necessarily know if you weren't here networking with others. Safety, your family and friends may be more aware of future risk situations. There are going to be some cons as well. The stigma, sometimes people are going to start to treat you differently. A loss of independence, sometimes people will automatically put you in a patient role and start doing things that you can very well still do. Employment concerns, if you're still working, you may not be considered for promotions or other new responsibilities, and they may kind of start talking and pushing towards early retirement. It can be emotionally burdensome, not only to you, but to your family members as you're sharing this information. Privacy, we kind of want to protect our personal health information. Relationships may change. People don't know what to say or how to act. And sometimes it's denial. Sometimes we're just not ready to talk about it. Caregivers and care partners can easily become burned out, and sometimes it's because they just don't recognize those things in themselves. People who are caregivers have a 53% higher mortality rate than those who are not caregivers. And that's because sometimes they get so caught up in the day-to-day work and the day-to-day emotions that they don't take good care of themselves. What we can feel are stressed, that we just can't cope anymore, feeling like you're on an emotional roller coaster, juggling care and household responsibilities, health issues with your person, finances and relationships. Sometimes we feel irritable, we just snap at the first person, and it could even be the loved one that we're helping. We could become suspicious of other people's motives, have difficulty modulating our own emotions. We may be overreactive or just have no reaction at all. Physically and emotionally exhausted, feelings of depression, drowning, or being overwhelmed, or the opposite, being very anxious. Do you ever get so anxious and frustrated that you kind of feel like your breath catches right here in your throat? That's can be from a lot of anxiety with caregiving. Overreacting towards family or care recipients. Withdrawing from things that you enjoy and your opportunities to socialize. There are health issues, muscle tension, body aches, headaches, changes in appetite. We see people who become very thin because they're not eating well, or overweight because they continually eat. They eat out of stress. Changes in sleeping patterns, deprived or too much sleep. And earlier, as you know, sleep and stress go hand in hand. Illnesses because of a weakened immune system. So kids are back in school, they're around you, they bring home a little cold, and you become very ill with it. You just kind of catch everything that goes around. And sometimes, unfortunately, it also results in the increased use of drugs or alcohol. How do we get there? Well, sometimes it's denial. Consciously or subconsciously, we're denying the needs that we have as care partners, or the disease process, or maybe just that we're starting to feel burned out, so we deny those feelings. Sometimes it's out of guilt. There are times in a care partner's journey where you need additional outside help. And those decisions are hard to make, whether that is in-home care or it is having to make a decision about placement options. And those decisions are difficult and very traumatic for family members. It's a lack of control. You can't control this disease process. It is ongoing, there's no cure, and it's progressive. Control of the situation, control of others resulting in feelings of failure, and unrealistic self-expectations. I can or I must do it all. AARP offers a caregiver quiz, and if you're curious about where you are, or if you're starting to feel like you have some feelings of caregiver stress, this is a great option for you. You can just Google AARP, and these are the questions they ask, but they also give you a scale on how often you feel this way. We use a training video for our staff, and there's a little lady that's in the moderate to severe stage of Alzheimer's, and she repeats this to herself: refresh, refocus, and renew. So we're going to use Marcy's words for a minute. If you would, get real comfortable in your chair. Put your feet flat on the floor and close your eyes. Put yourself in a wonderful place. It's a place that you enjoy going to. Look around you in your mind. What are the things that you see? What are the things that you hear? Is anyone there with you? If they are, they're there by your choice. Okay, join me back in the room. Where did you go? I go to the beach every time. I hear the seagulls. I hear the water slapping up on the sand. I can feel the sand under my toes. I may have my husband there with me. It just depends on how quiet he's going to be today. If he's going to be talking, he's not in my place. Did anybody go anywhere else? Yes, sir.
I went on my deck.
On your deck?
I
Okay.
live on the White River. I saw my boat. I saw the river. My wife was with me. And I heard the birds.
Good for you. Good for you. Where did you go?
I went to the swimming pool.
The swimming pool.
Lap swimming, all by myself.
Okay. Nobody talking to you, right? Okay. Anybody else? We all go different places, don't we? Although as I do this in class sometimes, a lot more of us are at the beach than anywhere else. But most of the people are 20 years younger than I am, so they have different places they go as well.
Everybody was by water.
Yep.
River, pool, you were at the beach, I went to the pool.
Yep. Yeah. One lady actually said she was at the park playing football with her grandkids. And I thought, okay. As we mentally bring ourselves down and our breathing changes, as we go through this process of refreshing and refocusing our attention, are we in a better frame of mind or a different frame of mind? And that gives us the opportunity to renew ourselves, to just take a couple of minutes and refocus where our brain is. And sometimes it's not easy, but sometimes if you can do this in the middle of the storm, it will help you feel more grounded. It'll help your breathing. To breathe in slowly while you're in your pool or on your deck or with me at the beach. As long as you don't talk, you can come with me. How can I do this? Well, for all of us, that's different. For a lot of people, it's writing in a journal, maybe reading affirmations. For a lot of us, it's prayer. It's time in prayer. Our spiritual feelings can help ground us. It can be breathing exercises, meditation. It can be physical exercise, swimming laps. It can be repeating things that you know make you feel good. It can be reading scripture. Some things that we can do are keeping things simple. When you have a lot of projects on your list, what can be deferred? So If you are a person that really, is very aware of what your house looks like and it has to be meticulous, can some of those things wait till later? Can they be delegated to others? I read where a lady suggested making a Christmas gift to herself, and that was, when you had children growing up, did you ever have a job jar? Do you know what that is? Where you tear slips of paper and you put jobs in, the kids have to draw out a job? Do it now. But for the people that are asking, what can I do? How can I help? Let them draw something. Or give them something that you know that they can do that matches them. People want to help, but so often they don't know how. They don't know how to ask, and they don't know what you need. And then what things can you drop? What things can just go by the wayside that you don't really need to worry about? Processing and releasing emotions such as guilt, anger, and frustration. And go back to focusing on some fun things. What are some things that you and your loved one enjoy doing together? Does anybody like to work puzzles? Okay. How about like crosswords and things like that? Okay. Watching movies? Okay. What are some of the other things that you like to do together? Scrabble? I know a lady that they do Scrabble like every night after dinner. They sit and play Scrabble together. Make the time to do the fun things. Are the fun things more important than the dishes? Yes. Yes. Are the fun things more important than whether or not your bed's made? Yes. Can you make some of the day-to-day things fun? Sure you can, right? Because we can do it together. What if setting the table becomes something that you work on together? What if he now runs the sweeper while you're doing the dishes? You know, some of the things that we do to people when they have an illness, a chronic illness, is that we start taking away all the responsibilities. When we do that, we're also taking away a person's feeling of purpose. In long-term care, what sometimes happens is we actually make patients worse. And we do that because we start dressing them. We're brushing their teeth, we're combing their hair. When they're taking a shower, we're washing them. And chances are they could still do a lot of those things for themselves, right? But it's easier and faster and more efficient if we do it for them. But we're actually making them more dependent on us. And sometimes as you become a caregiver, you start doing things for people before they actually have to have that assistance. Not everybody likes to journal. I don't. I think it's great, and I think a lot of people really enjoy it, but sometimes you just don't know where to start. As a care partner, I think there are some important things to write about. And those things are the positives. How did he look in that blue shirt? Now, my husband has blue eyes. The first time I met him, he was wearing a blue sweater. Well, that was the end for me, right? Because I just love how he looked in that blue shirt. I love how he laughs at a funny program. He laughs loud and hearty. So those are the things that I want to remember. I don't want to remember that he left his shoes on the floor again. Or that when he brushed his teeth, there was some spit in the sink. Those aren't the things I want to focus on. I want to focus on the good things. So I'm going to write those down. I'm going to write them down because as his needs change, he's not going to be able to do those things anyway. So I want to remember the good things about our relationship. How it still feels to hold hands. How it felt to walk down the street today. How it felt to sit here together in a group of people. Stay involved with your loved one. Don't let them become a patient. Walk, or better yet, dance down memory lane. We all have great memories together, don't we? Let's talk about them. Sing or listen to or even dance to our old favorite songs. Laugh at old funny stories, especially about things your children did when they were little. Read out loud and discuss things. And over time, those may need to be smaller things that you're reading and discussing, but still do those things together. One of the things that we suggest for people with cognitive decline is that they keep challenging themselves, playing games or doing things together that kind of still spark your memories and things. So watching even Jeopardy or Wheel of Fortune together and solving the problems. Playing games and working puzzles such as crosswords or trivia. If you are watching TV together, I would recommend that you don't watch things with a lot of violence. Sometimes people with Parkinson's and other types of dementia process these into their dreams. So the things that they're seeing on television become delusional for them and cause a lot of stress. If you want others to be happy, practice compassion. If you want to be happy, practice compassion. I deserve to be surrounded by people who love and respect me. That can be the people in this room. That can be your family. If you're going to put a photo on the other side of this screen, who's going to be in it? And do you deserve that? Of course you do. At the end of the day, at the end of every day, thank you for showing up today. Sometimes we're just, it's just kind of going through the motions, but tomorrow's a new opportunity. I thank you all for inviting me to join you here today. This is a wonderful opportunity. Are there any questions? Okay.
Thank you.
Thank you.
Thank you.